technical implications. And to be honest, I was planning to come to listen, to learn, to get myself educated about their chronic, and then over as if I will present. It's like, okay, what, how can I help? So I put together my perspective as a clinician working in the with a lot of patients with rare and ultra genetic disorder, with developmental impact, and I'll try to share. It's going to be helpful, but at any point if there are specific things that anyone is interested in, and I can be helpful to ways. So I'll try to go through some logistic challenges, and from that look into opportunities to treat neurodevelopmental disorders. What things every day. How what I've learned from other genetic developmental disorders, potentially the first I'll keep to address some clinical care challenges and gaps, and what are some of the focus getting to this clinical care, and then thinking through some of the ways to build the trials and interventions. I'm going to put my background only to tell you where I'm coming from as far as what's been my experience and what are the things that I take and I try to think through these issues. I'm a physician. I'm also certified. First, I was certified in pediatrics, and then I went to child-neurology and developed with epilepsy. And I've been in TNC since 2012. And my clinical and research focus is neurogenetic disorder. As pediatric neurologists, we're all kind of general pediatric neurologists. There is very few people that can really focus just, we basically see multiple of the whole range of pediatric neurology, but specifically also neuroimmunology, with this kind of field that I'm more interested in. And since early on in my career, I realized that genetics is going to play a huge role in a lot of our patients, neurologists, and we created this collaboration with geneticists, genetic counselors, and some of my colleagues in pediatric neurologists, in pediatric neurology, epilepsy neurogenetic. And we call it epilepsy neurogenetic, not to step on anyone's toes, because neurology has lots of genetics, but it's actually wider than just epilepsy. It's neurogenetic disorder manifesting in childhood. And I believe that the clinical side of things, one of my colleagues, Dr. Hunter, does a lot of the more basic science. She's a clinician, but her interest is in diagnostics, in figuring out diagnosis of patients that did not reach a diagnosis in the usual through this work and through my patients, actually, we brought to UNC Centers of Excellence called Rett syndrome, Batten disease, and DRPLA. These are three rare genetic disorders, and each one of them has taught me kind of for some of the ways to address both clinical but also research in the field of rare genetic disorders. Also, through my patients, I became involved in clinical trials. And currently we have a stroke trial. This is pharma sponsored in Dravet syndrome, SNYA. A gene therapy AD9 trial in magnitude Dravet syndrome. We also, I'm also the principal investigator of 2 and of 1. So it's one of the one is 1 and 2 in it's a cell and 3 glycogen disease and it's cell 3. I'm also involved in natural history and real world registry studies, and these are the 3 foundations that were Center of Excellence in. Each one of them has their own version of natural history. So it's the Rett syndrome, the Batten disease, and the other. So thinking through people care in genetic neurodevelopmental disorders and some of the systemic and logistic difficulties that there are able pages. So to start with genetic neurodevelopmental disorder, especially the most of them would be rare or alternative. There's always frequently a sense of limited expertise and awareness of these disorders. This is among healthcare providers. Frequently, there's a need in fairly complex multi-system involvement. So it's not just the development, but it's just like GI, cardiac, pulmonary, a lot of other system involvements. There's complex health needs. The caretakers to navigate the complex medical system with multiple specialists or to be the caretakers become the complex care navigators of these complex systems. And there's limited access to care coordination with the healthcare provider. As healthcare providers, I know I can guess that many of you are sitting in front of a doctor who will tell you, well, I never heard this problem, and I don't know what to do with this. I never heard of you any, or I never heard of any other genetic disorder, which I can imagine. Well, I cannot imagine how difficult it is to sit in front of someone who's supposed to provide their care, and they tell you, oh, well, actually, I don't know anything about. But I want you to, and I know that this is super difficult. I get it, but I want to take you into the shoes of someone who's sitting on the physician end, and it comes with you how awkward and difficult it is for care providers to be telling that they don't know, they don't have personal experience with a specific disorder, which is one of the reasons I'm here. I was like, oh, I want to meet families, I want to listen to the science. But also, each one of the specialists is used to taking care of their specific system or organ, and now we're looking at a disorder that has multiple system involvement, and it's very complex, and you have to understand how the impact of what I will do in neurology will have on other systems that potentially impact on. Then my next slide is a little bit about the specialized or physicians' sense of lack of confidence with genetic, especially rare genetic disorders, and to put all of this into the context of the healthcare system and also to see patients in half an hour. My field is kind of where we have to watch for half an hour. a lot of others only don't have half an hour. And half an hour is nowhere near enough time to see a patient with complex disorder. And then I put together just a few other area jobs, to genetic testing and to specialists. Lack of evidence-based guidelines of care. The complexity of behavior education management, and then the huge burden of families and caretakers, and on the other hand, frequently very limited resources. So this is just kind of, again, to give a little bit of what it looks like physicians. So this is a study, it's a survey in 2014 that asked adult and pediatric neurologists and epilepsy specialists, what is their level of confidence of taking care of patients with epilepsy associated with genetic syndrome, with intellectual disability, and with autistic features. And I kind of flew up larger. The confidence in dealing with epilepsy associated with genetic disorder. 9.8% of adult neurologists feel confident in taking care of this patient population. 53% of the neurologists. Their confidence of dealing with severe intellectual disability was. This is terrible. And this is something that definitely we have to do better with. But this is just not specialists. They pride themselves on being specialists in taking care of patients with neurological disorder. These are common neurological disorders, and yet they don't feel confident taking care of these patients. In the child neurology world, we were more comfortable with the complexity of rare disorders, but still frequently neurologists, even child neurologists, not feel confident in their level of knowledge. So how can we do better? Some of the models that I feel are for our multidisciplinary clinics and care coordination. Easy to put together. This is an example of the Batten disease, the BPSLA organization that in so Batten disease, these are genetic disorders. Actually, Batten disease itself is rare, but among Batten disease, there are 14 different subtypes. One of them is addiction changes, so it's a model Batten disease, but they have a lot of clinical similarities. So this is organization that research and testing in care in 2023, 2023, 2024. We started Center of Excellence, and this comes out of the criteria. What is that requirement to be a Center of Excellence? And part of that was a clinic, and this is just an example for this disorder. So it's possible. It's in the center. It's the people of Batten disease, and there's family care coordination. Which the healthcare system will outcome from the evidence to file stable way, but there's a neurologist, a clinic coordinator, triage line, and a social worker, a counselor, rehabilitation medicine, palliative care. All of this we actually do have TNC, so we were able to get this designation of Center of Excellence. subtype of Parkinson's disease needs help with more surgery. So ones that are required for surgery, ophthalmology, which is a major problem. Vision is a major problem with this disorder, and then medical genetics. So through these centers of excellence, it actually motivated the PNC to put in the resources to listen to us when they say, hey, we need to put together a clinic that sees these patients one place where we can work with the stationaries, with the physical therapists, with rehabilitation, with palliative care, all of us at the same place at the same time, work through the patient problem together. So kind of pushing the healthcare system to make these system changes, it was very helpful to come and say, hey, we have this designated center, national organization is requesting us to put this together, and the healthcare system it just yes, is very motivated to do the right thing. So it made it possible. And public care guidelines, this is something that can be very helpful both for families to be able to have a checkboxes. Okay, so see once a year, my always just wanted to know some basic suggestions where, and these are the examples that the syndrome. There's fairly comprehensive paper that comes out of the Resident Foundation. The basic things about what assessment to do a baseline, what assessment to do yearly and every 6 months, and it goes through multiple systems of and it will put a specific question to ask. And this goes on, this is kind of the for this for specifically for Rett syndrome. Next, it's extremely helpful for clinicians, but also later will tie to research is clinical expert network. So that the Rett syndrome, similarly, also the other two organizations that we work very closely with. The Syndrome Excellence as a network, meeting once a month with other clinicians over Zoom to go over specific clinical questions, research question, advocacy, meeting with the annual meeting for this which is very helpful in setting out first as so for the Rett syndrome. Actually, when we set out multidisciplinary clinic for the clinic, we came actually here and to see how the clinic is into sports. That right walked us for what they together for their clinic, which is the one of the so having the support of other clinicians, how to create the system with all the specific patient questions. So if you have a specific usual presentation, I balance that those in more patients that might want the same clinical presentation. So we're going to the clinical trial readiness. I typically think of the mom. This is the reason that I started doing clinical trials. So this was a mother of a child with Dravet syndrome, and this was it was about 2013, 2014. There was a big news reports of CBD and cannabis in epilepsy, and but North Carolina there was no cannabis. It's like Schedule 1 drug. It was like possible for them to ship it from from Colorado. And the mother said to me, the whole pregnancy can put together a study, bring this drug to my daughter. And he was like, if you and C can put it together, why are we even here? This is kind of what led to the first trial that I brought GNC was the CBD now diagnostics. So what are the elements to get us ready for clinical trials? So to start is to establish a diagnosis. So working with making sure that there's access to genetic testing, the patients are tested, and that there's genetic counselors that they also make these diagnoses. Then we need to connect with patients. We need to create, and frequently I find that it's families that are the driving force to bring together patients and researchers to create this community that's looking for research. Thinking through what are some barriers to get into a diagnosis, and I find that one of the big ones is awareness. I think these days people are fairly aware of checking for genetic disorders, but I've never heard of neurodevelopment until I saw a patient with this disorder. So frequently, just getting to clinicians, getting into families and saying, hey, we're here, come and join this specialist awareness. I said, kind of talking about kind of how frequently even neurologists don't feel confident in their knowledge, so spreading kind of more disinformation. We started as clinical assessments that patients can self-collect data. The registries and longitudinal follow-up, creating these sample history data, well defined these disorders. Very important is finding what are meaningful outcome measures. So that when designing a trial, we know which work goals are to achieve, and looking for biomarkers and when for follow. And lastly, kind of creating is a way to access it to get patients when we start enrolling patients for a trial. So I a few slides to just kind of thinking through your 1A in this kind of these learning experiences. So multidisciplinary clinic, this is limited resource, but it made me again think that we need to expand on what we're doing with the genetic. So currently, if I have a patient with Batten disease or a patient with Rett syndrome, we have specific slots. We have the clinic, and we call patients to get them. Unfortunately, since many of our patients do have genetic disorders, we have limited to those specific disorders that we define. But I do think that blinder patients would benefit from the same setup. The clinician doctor, the therapist, so kind of extending, message to myself, extending on what we're doing to extend it to other disorders. Another thought is kind of the model that with some disorders, some genetic disorders, where there's a specific center, say Boston Children and North that has a specific clinic that sees multiple patients that come from all over the country, and that specific center serves as support for the whole neurologist. So I have patients that would go to CHOP for their specific genetic disorder, and then you come back to me and communicate, hey, they thought maybe we need to go more of this or less of that, and kind of simple center that is, and there's obviously advantages and disadvantages of either one of those. Their coordination is really difficult. There are a lot of larger centers that have complex care clinics that can become a medical, oh, I know what you see, we're fortunate about that. But for many families, it's yet gathered from the sea, so it doesn't hold for it's a medical and larger centers you have that access to the complex care clinics. Clinical care guidelines. So this is from gene reviews. So I don't think that there's a so that is already on the gene reviews for their 1A that is not far from turning heavily into clinical care guidelines. So that and clinicians use gene reviews very closely. So when it's usually the first place we go when we get a diagnosis to kind of get kind of all the clinical information. So the fact that your 1A has gene review pages, but of taking that clinical care guidelines is very close. Just that this is the other treatment. But I said you also. So kind of going from clinical care to research and trial readiness. So first is the diagnosis, establishing a diagnosis frequently comes from either pediatric, genetics, or neurology. Identifying patients, so the recommendation is gene reviews, the tier 1A that already exists, the family community, and the activities. This is really, all of these are major benefits. Reducing barriers is another consideration. Again, awareness, I feel like it's both for specialists and for multidisciplinary care. So really important. Dr. Guy's clinical assessment, including neuropsych imaging, system evaluation, can help you build in the database. So having, if there is a clinical care guidelines and families can follow that, that can be hopefully used to create these databases and inform the registry for this data. As described, creating the natural history data is of great importance into getting into therapies, being able to show is it beneficial and what is the impact of intervention. And along with that is looking for meaningful outcome measures, biomarkers, and then getting the community set up for enrollment, straight for enrollment. Just kind of some of our team in the disability clinic. We had in the center, we had the disease family day. This was last September. We had the EFC has service dogs that highlight for the kids. about it from the parents, some of the parents, and then also the genetic should be able to.
Thank you for that presentation. That was absolutely wonderful. Does anybody have any questions?
So something you touched on was this small multidisciplinary team. I mentioned it has to be close to Baltimore where they have a Kennedy Krieger Institute. And one thing I love is that my son has been learned that pretty much since we moved to the country. But now that he's turned 22, it's all about healthcare, and they will no longer want us to go there. We want to do if he's covered under Social Security, all the ISO stuff. So it's like trying to get them to understand they've been following him this time. Please stay in this multidisciplinary model because this is more beneficial than trying to go to these different dogs and all these different places and explain yourself everywhere you go and what it is. And I feel like it's sometimes it's just tied to health insurance, unfortunately. So is there anything like you would suggest, to our families? Because I think that's key. Having a multidisciplinary team has been so beneficial for.
This is a huge gap in the healthcare system. So the transition to adult is frequently when going, us not necessarily different suicides for pediatric age group. When you move to adult, it really is even greater challenge. In the Shiloh-Malawsky Society, there's a lot of discussions about it, and many of us believe that child onset disorders are best served by pediatric neurologists because we know that these patients, since they're young, and is a group of disorders that work and set up to care for. I can tell you that so UNC is working to it's not UNC. UNC and Duke are moving to a children's hospital. It's only about 10 years, but now there's a lot of talk of setting up the children's hospital. And my one question to the chair of pediatrics was like much more of a request to keep within the children's hospital child onset disorders. So these patients, when they turn 22 or 18 or 26, they don't have to wait. Then we can continue to take care of them. I don't know how to do it on a system level, except for advocating that I do believe if we look at, for example, oncology, pediatric oncologists continue to follow their patients throughout their lives. Patients with cystic fibrosis continue to go to the pediatric pulmonologists because they're the expert in taking care of cystic fibrosis. So, and I hope that we can have similar goals.
I think I had that they did start, it's probably about 3 years now, something called the Lifespan Clinic in the Kennedy Krieger. And I feel like the title is like lifespan, so they're going to follow you in your lifespan. But again, it's the insurance that doesn't want to cover it. So that's my issue.
And you mentioned in terms of we already have like a chief reviews for 1A syndrome, and that potentially serve as the basis for clinical care guidelines. In terms of moving that needle and how that's set up, is that like a group of physicians need to get together? So it would be like experts in, let's say, your 1A syndrome that sort of develop a plan for clinical care guidelines. Is that typically how that works? And like, If so, is that something maybe it's like a foundation you can help kind of facilitate? Because I think, between yourself, Wendy Chung, she's been involved with One syndrome, and, I think there's been some other clinicians who have attended, previously. Is that something like we as a foundation can help kind of connect the dots so that we can follow something like a clinical care guideline?
Yeah, I think that's going to be very helpful to have kind of framework outlines, and there's many different ways to write clinical guidelines. Some organizations do have this whole process of consensus around, but frequently it's clinical judgment in my mind. But we can do it very scientific. Bottom line would be literature and recommendations and getting ready to be listed. Obviously, we didn't allow slowing get confidence in that. So yes, I think that and I do think that we're almost there, and putting that together in my mind also with standardized assessments and with data collections, so that can become also a basis of natural history type or registry type of data collection.
When you say natural history, because that was when the NIH has the Rare Disease Day in February every year I attended. And one of the things they talk about is getting this toolbox and how to get those natural histories. Is it, again, it's a key to collect the data. And we try as hard as we can on our Facebook page and asking people to, please try to be a part of the trials and the different organizations we work with to collect the data. And is there like a point where there's enough people, or what is it they look for? Is there a number?
The good question, but I actually don't know if there is, because even so the DRPLA put together a fully sponsored natural history with people from all over the country and in multiple sites in the world going to get MRIs and the assessments. And, so a huge effort, and the number of patients comes to about 50, which sounds like not too many, right? And yet it's going to be kind of the largest data collection for that disorder. So I think that any data is data. So I don't think it needs to be, like disorders, there's no studies of thousands of patients. As long as, if possible, get enough similar assessments so that you can group them together. So I think that's kind of the key to say, okay, we selected to try to follow similar for as many patients as possible.
Yeah, there's the maybe